Next, after we've entered the abdominal cavity, first thing we do before proceeding to surgery itself, we have to perform the abdominal exploration. In this part, you have to investigate all that is available for sight, not only the place where there is a disease you are about to treat, but all available parts of the abdomen and all available organs. You must see if there are some additional pathologies which can be visible only through direct vision during operation, or you may see the spread of certain disease you've diagnosed or a newly diagnosed disease, and that's what you begin with after you've entered the abdomen. If you didn't find any additional findings, you describe the zone of interest. For instance, in a right iliac fossa, cecum, appendix, and distal loop of small bowel are observed. Next, you describe the appendix. You may write here that appendix is enlarged in gross size. Its walls are thickened. Swollen. It's in a state of hyperemia. And if this is a destructive appendicitis, in most cases it's covered in fibrin. Sometimes, if the destructive process is advanced, appendiceal wall may carry signs of partial necrosis. Beside that, you can, in many cases, you will see that surrounding cecum is also hyperemic and swollen. In other cases, you may find pathologic effusion in right iliac fossa. In italics, it would be better if you relatively uh, calculate the number of this effusion. Let it be about 30 milliliters. That's usually what you see. Next, after all your macroscopic findings, you write a short conclusion that all these findings can be interpreted as macroscopic features of an acute destructive appendicitis. But don't forget to examine maximal amount of the abdominal cavity, and in the end of this section point out that available abdominal regions, that means, for example, that you won't be able to reach the spleen or left colonic flexure from right iliac incision. That's why you simply can't investigate those regions, because you don't have sufficient access. So available abdominal regions, we know that they include right iliac region itself, right lateral region, pelvic region, and paraumbilical region, with organs which are located in there. So if you didn't find anything specific in those regions, you write down that available abdominal regions carry no signs of visible pathology. So that's when the abdominal exploration section ends, and after that you describe the surgery itself. We will describe a standard appendectomy, and this surgical procedure usually goes as follows. First thing, you begin with appendiceal mesentery. You have to reach its basis where appendicular artery and vein is situated. Then you have to dissect it from the basis of the appendix. You have to put a clamp on that. Then you have to transect it and ligate. So let's try to write this. So appendiceal mesentery is released. Dissected from appendix, basis, and cecum. Clamped with Kelly clamps. Transected with, let it be, Metzenbaum scissors. And ligated. means that you take a thread, a ligature, and you tie it around the clamp to avoid bleeding from appendiceal vessels. After you've done that, you reach the basis of the appendix, and in a same manner you clamp it. You cut off the appendix first, so basis of the appendix is identified. You have to make sure that you don't take an excessive amount of cecum in your clamp, and you don't cut off a part of cecum. That's quite frequent beginner's mistake in doing appendectomy. Then appendix is transected and ligated. Next, to avoid micro spillage from the ligated basis of the appendix, you have to invert it inside the cecum cupula with a Z-type stitch. Z or purse string suture. That's actually when appendectomy ends. You have also to note out that the specimen is extracted from the wound. It would be correct if you put it not in here, but here. That will make more sense. Next, after you've done that, you can write down that you've used the antiseptics measures inside an operation wound. For example, you've rinsed the operating field with a solution of antiseptic. In situations when the inflammatory process was extended, you may place an abdominal drain at the site of your operation. one single drain, usually it's enough for appendectomy. Now here is when the operating maneuver, the surgical procedure ends, and after that you proceed to a step of reconstruction. Reconstruction here is performed in a reverse manner. First thing that you stitch is parietal peritoneum. Next, posterior sheath of the oblique internal muscle. Then muscles of the anterior abdominal wall. Then aponeurosis, subcutaneous fat optionally, and finally skin, were consecutively stitched. And after you've completed the reconstruction, you must point out that a sterile wound dressing was applied. So that's it for the description of an operation, and after you've written that, you do a finalizing part of operation description. Now pay attention that what was the final diagnosis, it remained final diagnosis. We didn't find any additional pathology either in the abdominal cavity or pelvis. That's why our preoperative diagnosis, it turns out to postoperative diagnosis, and it's the same as our final diagnosis, which we've mentioned earlier. So we didn't find anything new. Our preoperative diagnosis was correct. We've performed an adequate surgical procedure. We didn't have any intraoperative complications, no blood loss, no perforations, no nothing. Our operation passed in a standard manner, and this is where we finalize. After establishing postoperative diagnosis, we describe what we've taken out. So our gross specimen this is appendix with its mesentery. We point that out because everything we remove from patient's organism must undergo pathologic examination. We will give that gross specimen to pathologists. Pathologists will confirm our diagnosis micro macroscopically, so we would be safe from some appendiceal tumors or some other diseases which look macroscopically similar to appendicitis but are not. For example, inflammatory bowel diseases or something else. So we obviously have to give that gross specimen which is removed for pathological examination. And finally, we can point out here that no blood loss occurred. We didn't have to perform hemotransfusions because we didn't lose that amount of blood which requires hemotransfusion. So that's it for the operational protocol. That's where it ends. It always ends with primary surgeon's signature. And I forgot to mention at the very beginning, after identification of a patient, we must always write down date and time of operation. For example, the operation took part on April 24th, 2020. It lasted from 15 until 16 hours. This precision is very important. You always have to point that out in your operation description. Okay, so now we're done with description of operation. We're done with surgical part. After surgery, the patient will be admitted into his ward, and he's going to receive post-operative treatment. And that is another section of a surgical case history where you'll have to describe post-operative treatment. Well, first thing, as we've had a deal with acute appendicitis and local peritonitis, we have a systemic inflammatory response syndrome. We are aware that there are certain amount of bacteria still inside the patient's abdomen, so to avoid their further spread, we have to administer him antibiotics. You will have to write down the name of at least, not at least, name of one antibiotic in a correct pharmacology manner. Let it be cefazolin. Of course, after each surgery, any patient will experience pain. So, to avoid that, we have to administer him some painkillers. Usually, after such kind of surgeries, certain NSAIDs it's enough. So here you'll have to write down the name of one NSAID drug in a correct pharmacology manner. What I mean as correct pharmacology manner, you may see that in your manual here. There's an example of metformin for diabetes mellitus, or another example. This is enalapril for hypertension, and you will have to write antibiotic and NSAID in this manner which you were taught to do that in pharmacology class. Next, what we also can administer this patient, we have to take care of his nutrition. You'll have to write down some dietary recommendations. And of course, another very important point of surgical clinic, you'll have to take care of the wound. You'll have to change his wound dressing. And you will have to write down what happens with the wound. That's regarding our topic about wound healing process. We expect that his surgical wound will heal with primary healing, with primary scar, and there will be no infectious complications with that wound. After you've described the postoperative treatment section, you proceed to journal of follow-up. In your follow-up journal, you'll have to do a similar thing. You point out the date. First date, it's usually written as postoperative day 1. Here you give the exact date. This is day. Date, month, and year in such a date manner. Then, when it comes to clinical status, you describe briefly his clinical status, which includes general condition, vital signs, complaints, and briefly physical examination by organs and systems. Not in such an extended way as you've done in the previous part of a case history, but very briefly, very exact stuff which is related now to his postoperative period. Next, after you've written that, in a specific subsection, you'll have to write down his local status. Local status is everything what is related to operative wound and drains, like everything related to surgical site trauma. So we have two sites of trauma. These are surgical incision here. You have to point out the type of wound healing. And if something seems wrong to you, you must point out macroscopic signs of wound pathology. So that's enough for surgical incision and abdominal drain. Here you describe the amount of effusion usually in milliliters daily, and also you have to mention macroscopic signs of pathology. And at the end of abdominal drain subsection, you must point out that, for example, drain was successfully extracted on postoperative day 1. So this is enough for clinical status. And so clinical status and local status. And next, treatment. As a conclusion in this journal of follow-up, you write down what treatment are you going to administer to this patient. For example, you're going to leave him antibiotics and NSAIDs. Here you write down the daily dosage and way of administration. That is per oral, intravenous, or via intramuscular injection. You end up the journal of follow-up on postoperative day when the patient gets discharged. For example, you wish to discharge him on postoperative day 3. You write everything which we've discussed previously, and after treatment section you write out that patient's postoperative period was uneventful. It means that he didn't have any postoperative complications or some other health problems which might not be directly related to surgery. It means generally that he's alright, he's doing well, and he has no further need for staying in hospital. And next sentence, its final sentence, you write down that on such date at a certain time, hours, minutes, the patient was successfully discharged from the hospital. But of course, you understand that you can't just throw this patient away and don't give him any additional information. The additional information you give to your patient is known as recommendations. It's very good written in your manual, so you have to write down once more acknowledgement that you give him recommendations. Well, acute appendicitis is not such a big deal. Those patients don't need no follow-up. They don't need any further surgical treatment, so you can give them just general recommendations. It's lifestyle and diet recommendations as it's written here. This will be enough for a patient with acute appendicitis. And at the very final of your case history, you write his prognosis, it means that you have to point out some of probable patients' disabilities or further healthcare problems which might be directly related to the treatment you've given him. So, prognosis for life for those patients, nothing average. For health, well, as he has an operative wound on his abdominal wall, this will turn into a scar, and the scar on the abdominal wall might transfer into incisional hernia. So for healthcare problems, you can point out that the patient must be aware of developing an incisional hernia at surgery site. And for workability, acute appendicitis usually doesn't reflect on patient's workability in no way, so here also nothing special, nothing average. And you complete your case history with epicrisis. So briefly, what is epicrisis? It's an analytical summing of a medical case history. You should briefly describe all significant data which may characterize current clinical case, anamnesis, physical findings, results of diagnosis, prognosis. Well, in general, you can write down that a case history of a patient with acute appendicitis had been described. The diagnosis was made basing on complaints, physical examination, laboratory data, and radiologic data. Next, you can write down that the patient underwent a conventional appendectomy his postoperative period was uneventful. He was discharged on postoperative day 3, and couple of words about his prognosis and recommendations. And at the very end, you must give some references. Use the supplementary materials I've shared with you in our group folder. Write down a couple of references. You may find them either in the text or just use the name of those manuals I've shared with you, and that's it. This is when an academic case history is considered absolutely complete. So I wish you success in your preparation of your academic case history in a discipline of general surgery. I wish you good luck to pass your exams during the examination session, and I believe that all this tutorial will be useful for you, and something from what you've heard or from what you've seen from this tutorial will be used when you will become successful, brilliant doctors in the very near future. Thank you for your attention, and goodbye.